All right, let's jump straight into this explainer. When you're looking at clinical scenarios, your absolute first priority, literally the very first thing you do, is evaluate stability. If your patient's airway, breathing, circulation, mental status, or perfusion is unstable, you have to stabilize them before you even think about getting definitive imaging. You put them on a monitor, give oxygen, establish large bore IV or IO access, check their glucose if they're altered, and get an ECG if you're worried about cardiac or toxic issues. The whole point is to treat immediately reversible threats. Do not, under any circumstances, send a crashing patient to the CT scanner.
Section 1. Unstable patient first steps.
Okay, say you have a blunt chest trauma case. If the patient is hemodynamically unstable, you execute your resuscitation and immediately do an EFAST. Now, if you can't achieve or maintain hemodynamic stability after that, the algorithm strictly dictates you proceed immediately to an OR thoracotomy. The classic test trap here is choosing an advanced scan. Just remember, unstable, blunt trauma plus a positive EFAST means surgery, not a trip to the CT scanner.
Distinguishing cardiac arrest pathways is another absolutely crucial next best step scenario. Management completely splits based on the rhythm. For shockable rhythms, we're talking VFib or pulseless VTAC, you need immediate defibrillation, followed by continuous CPR and epinephrine. But, and this is key, unshockable rhythms like PEA or asystole do not get shocked. Instead, you just do continuous CPR, push epinephrine, and immediately start hunting for reversible causes. Now, this right here is a perfect example of the treat before test logic. It requires a really specific order of operations. If you suspect infective endocarditis, especially in a patient with a history of IV drug use, you have to get blood cultures from 3 different venipuncture sites first. You have to do this before anything else. Only after those cultures are drawn do you start empiric antibiotics like vancomycin. If you give the antibiotics too early, you're going to obscure the exact diagnosis you need to direct their long-term therapy. Moving on to Section 2, Pregnancy Bleeding Red Flags. This table is great because it contrasts those tricky third trimester bleeding traps. There's a strict rule you need to memorize. If there's vaginal bleeding after 20 weeks gestation, no digital cervical exam is allowed until an ultrasound completely rules out placenta previa. Let's break it down. Painless bleeding, think placenta previa. Painless bleeding with membrane rupture and fetal bradycardia, that points to vasa previa. On the flip side, painful bleeding with a rigid, tender uterus means abruptio placentae, which is often tied to hypertension or trauma. And finally, sudden, severe pain with a loss of fetal station, meaning the presenting fetal part actually retracts back up, that defines a uterine rupture. That's a massive risk if the patient has a prior C-section scar. Section 3, Postpartum and Ectopic Triage. So, if an ectopic pregnancy presents with hypovolemic shock, do not delay. Don't wait around for serial beta HCG testing or another confirmatory ultrasound. An unstable ectopic pregnancy gets immediate surgery, period. Conversely, if the patient is totally hemodynamically stable, has a small unruptured mass, and meets the criteria, you can go ahead with medical management using methotrexate. In these cases, stability strictly dictates your pathway. Let's look at postpartum fever, which branches based on how it responds to treatment. If a patient has a fever for over 24 hours postpartum, along with purulent lochia and uterine fundal tenderness, that's postpartum endometritis. It's usually a polymicrobial infection, so you hit it with broad-spectrum IV antibiotics, specifically clindamycin and gentamicin. But if that fever just won't budge after 48 hours on those antibiotics, and the rest of your infectious workup is negative, you need to suspect septic pelvic thrombophlebitis. It's a diagnosis of exclusion caused by an infected thrombosis in the pelvic veins, and it's unique because it mandates adding anticoagulation alongside the antibiotics. Up next, Section 4, Sickle cell and sepsis. For a sickle cell vaso-occlusive pain episode, your immediate stabilizing move is aggressive hydration and pain control. Depending on how bad the pain is, you're looking at NSAIDs or IV opiates. You have to break that sickling cycle, which is triggered by dehydration and stress, before you go digging into other complex etiologies. Now, contrast that simple pain with acute splenic sequestration. If a kid with sickle cell disease rolls in with hypovolemic shock, left upper quadrant tenderness, and a rapidly enlarging spleen, it means their red blood cells are pooling massively right into the spleen, like a giant sponge. You'll see a sharp drop in hemoglobin and a spike in reticulocytes. The immediate treatment here is isotonic fluid resuscitation and a cautious red blood cell transfusion. You have to be careful because those trapped cells can suddenly return to circulation and cause hyperviscosity. You also have to remember that a fever in a patient with sickle cell disease or asplenia is never just routine viral reassurance.
The most common cause of sepsis for them is Streptococcus pneumoniae, thanks to their functional asplenia. So you need to administer broad-spectrum empiric antibiotics, specifically ceftriaxone, right away to cover those encapsulated organisms. If you delay antibiotics to get imaging or definitive cultures, mortality goes way up.
Let's talk transfusion emergencies. The absolute most crucial point here is to stop the transfusion immediately if severe symptoms like fever, flank pain, dyspnea, or shock pop up. Stop it first, then figure out the reaction. A classic exam trap is differentiating transfusion-associated circulatory overload, or TACO, from transfusion-related acute lung injury, TRALI. Both of them cause respiratory distress, but look at the vitals. TACO features a spike in blood pressure, while TRALI presents with profound hypotension.
All right, Section 5, neurologic and back pain.
You know, most low back pain is totally uncomplicated and doesn't need any imaging, but it absolutely demands an urgent MRI if you see red flags. We're talking fever, focal spinal tenderness, a history of IV drug use, immunosuppression, current or recent cancer, or systemic symptoms like unexplained weight loss. If you see even one of these, you can rule out a simple muscle strain. You need advanced imaging to make sure you're not missing cord compression or an infection. Let's apply those red flags to suspected vertebral osteomyelitis. If your patient has a fever, back pain, and focal spinal tenderness, your very first steps are to get blood cultures, an ESR, and a CRP, followed by plain X-rays. If those inflammatory markers are elevated but the X-rays are normal, then you move to the MRI. And here's the heavily tested sequence. You must perform a CT-guided bone biopsy before initiating empiric IV vancomycin and anti-pseudomonals. You need that tissue culture to direct the long-term therapy, and if you give antibiotics too early, you ruin the yield. The bottom line here is do not delay treatment for the perfect scan. Whether you're dealing with an unstable ectopic pregnancy, a tension pneumothorax, or a crashing trauma patient, unstable patients require immediate, definitive stabilization before you even consider sending them down the hall for definitive imaging. Master your first stabilizing move and know exactly what tests can wait.